Good evening. Let's go ahead and get started. My name is Helen Lactis, and we are thrilled to have a very large group of clinicians and providers joining us tonight. I checked the registration page and we had over 475 registered attendees, so I can tell this is a hot topic of interest. About 85% of our attendees are OT, PT, and CLTs who are well-versed in caring for lymphedema patients. So we are pleased to offer some new information specific to the evolving presentation of breast cancer patients. Tonight, we are thrilled to have Dr. Stubblefield and Jenica Bartolotta, OT and CLT, to join us. Dr. Stubblefield and I have worked together on many educational presentations, and his content is always well received. He brings a wealth of knowledge from his current role as Medical Director for Cancer Rehab at the Kessler Institute and the National Medical Director for Revital Cancer Rehab with Select Medical. In his free time, he's an avid photographer and art collector, we just learned. So we look forward to some photos that he'll share this evening. Jenica Bartolotta is an OT and a CLT currently practicing at Barnes Jewish Hospital facility in Sullivan, Missouri. She sees quite a few rural patients who receive treatment in St. Louis, and she has worked hard to partner with the providers in her facility to reach patients who can benefit from her services. She has grown her cancer rehab practice, and she will share some specific tips, tricks, and tools that she has found to benefit the breast cancer patient population. So welcome, Dr. Stubblefield and Jenica. Thank you for sharing your experiences with us this evening. We will have time at the end for questions, so please submit your questions in the Q&A box, and I'll keep an eye on that and close out with the Q&A. So without further ado, Dr. Stubblefield, over to you.
All right, thank you, Helen. And I just want to thank the entire Tactile Medical team for inviting me. It's always so fun to do this, and I want to thank all of you guys for giving up your evening. I hope you're all sitting there with a nice dinner and maybe a nice glass of something, adult, and are enjoying the talk. Next slide. So I'm basically a cancer rehab doc. I'm boarded in internal medicine, rehabilitation, electrodiagnostic medicine. I view my role as one of two basic things. You can either think of me as a sports medicine doctor for cancer patients, or more accurately, a janitor cleaning up the complications of cancer treatment. That said, it's really my honor to work with Jenica tonight because I can't do this alone. I'm pretty much useless by myself. I get to look cool, make a lot of diagnoses, and then send people in to the therapist to really do this hands-on work and make our patients better. So next slide. So as already said, when I'm not playing doctor, I'm a wildlife photographer, mostly birds. So these are a couple of oyster catchers. You can figure out which one's the adult, which one's the baby. My only other disclosures is I'm the editor of Cancer Rehabilitation Principles in Practice. The third edition will be coming out early next year. So some new information in there. And, yes, I do collect art also when I'm not playing doctor, kind of a lot of guest bird art, as you can see behind me here. Next slide. All right, so what we want to do tonight is I'm not going to bore you too much with lymphedema. I'm assuming everybody who's on this call knows about lymphedema, but I want to talk more about chest wall lymphedema, how you evaluate it. I'm not going to talk so much about how you treat it. I'm going to save that for the expert, which is Jenica, but I'll talk a little bit about what a comprehensive plan looks like to evaluate and manage these patients. Next slide. All right, so you guys, I'm guessing, all know what lymphedema is. It's, just really this protein-rich, and that's important, fluid that's caused by damage or dysfunction of the lymphatic system. It can be from filariasis if you're in other parts of the world, or commonly here, it's secondary lymphedema, usually due to cancer treatment, radiation, tumor, that sort of thing. It's extremely common, probably underdiagnosed. In a lot of settings, certainly very difficult to diagnose in a number of our patients, which we'll talk about tonight. Treatable, but not curable, even with some of our newest surgeries and management techniques. But the days, at least for me, of seeing these big, massive elephantiatic limbs in patients, just pretty rare. Maybe I'm not in the right place, but at Kessler, at least where I'm here in New Jersey, I don't see that too much. Next slide. So there's a lot of risk factors for it. So the biggest one is the surgery, right? We all know the number of lymph nodes taken in a breast cancer dissection really correlates with how likely you are to get lymphedema. This comes to one of the things we're going to talk about a lot is breast conserving therapy, where we're doing sentinel lymph node biopsy of one or a handful of lymph nodes, not taking out an entire section. those patients generally do better than when we do a full axillary lymph node dissection of either the level 1 or more proximally the level 2 lymph nodes. We rarely get into level 3 and don't get into level 4 at all in these patients. And just for those of you who've never seen these surgeons, the surgeon's not sitting there going, pick, oh, one, hey, there's another lymph node. Look, glad I got that. What they're really doing is taking out a fat pad between certain anatomic landmarks. And nobody knows how many lymph nodes are in there until the pathologist starts dissecting that fat pad to see how many are in there. Then radiation. We're going to talk a lot about that because I think for our breast conserving therapy, I'll say this several times, the radiation is probably the biggest culprit in causing the lymphedema. Tumor obstruction, infection. We'll see a lot of patients who've had mastitis or have had complications from their surgery. They're certainly at higher risk. Heaviness. For me as a clinician, one of the privileges I have is to be able to prescribe medicine. These new weight loss medicines have been extremely effective in managing lymphedema. You guys probably all have had these morbidly obese patients who don't even have a reason to have lymphedema other than being morbidly obese who have it. I have a number of patients in my practice who have the morbid obesity and the cancer. I've been putting them on these GLP inhibitors, and a lot of them have been doing really well. I've even been deferring wasting my therapy days or getting them garments, sometimes for several months, because the rapid weight loss is actually really managing lymphedema. And then when you get them down to sort of their fighting weight, it's much more effective to take care of these patients. Age, your lymphatics, everything. I'm getting older. Maybe one or two of you are getting older. Things start to wear out as you get old, and the lymphatics are no different. Trauma certainly can do it, and chronic venous disease. We get a lot of patients who have just varicosities in the legs, for instance, and they will have edema and lymphedema even as a result. Next slide. All right, so just the typical treatment of breast cancer, and this varies, right? It varies depending on the stage, the histology status of the cancer, the hormone receptor status, if it's HER2 positive or negative, and a variety of other factors. But the basic, most common treatment paradigm is you're diagnosed, you go to surgery, you'll get chemotherapy, often ACT, you might get Herceptin, Perjeta if you have HER2 positivity. And then once that's resected, we give you radiation, usually about 50 gray. This is important, 25 treatments, sometimes a boost, sometimes a lymph node, sometimes not the lymph nodes. And then the impairments that you get from this treatment generally will start improving, not necessarily go away. That's a subject of a whole nother talk or seminar we can talk about for hours, but they generally get better. You will often, and I'll show this later, get some swelling during this treatment that often will get better if it's kind of post-treatment, post-operative swelling, but often that is a harbinger of lymphedema, which can come up, months or even years later. Next slide. So breast conserving therapy. This is really, become one of the latest and greatest treatments. Very few women want to completely lose their breasts as a result of the cancer. And in early stage cancer, it's becoming progressively less necessary. We can take out the tumor, right, doing just a lumpectomy or a partial mastectomy, sometimes even nipple sparing or skin sparing types of mastectomies. We'll do a sampling of the lymph node. And then depending, there's even less radiation, but often radiate the patient, sometimes just put them on hormonal therapy if it's ERPR positive, right? So there's a number of ways that, again, is dictated by the nature of the cancer itself. So here's a young woman in her 30s who got breast cancer. You see in her right upper chest, she has her port, so that's the normal side. On the left side, you can see a very small scar on the anterior axillary line, which is where we took out the cancer, and her left breast was not larger than her right breast before. And her arm really doesn't have a lot of lymphedema. So this is my typical, when I got slides from, forgive me, from Tactile, they were fantastic slides, but it's always showing the worst of the worst. Most of these patients that I see, the breast lymphedema is relatively subtle, just like this. And this was a very sophisticated patient. She was a psychologist, and she knew that she was having breast lymphedema and also some cording in the axilla. Next slide. All right. So what's the big cause of it? For a lot of these patients, it's the radiation. That patient, even though she didn't look like it, had been radiated already. So next slide. So what is radiation? So we're all using radiation now. You're looking at me coming to you through the computer, Google machine, and Zoom machine via photons. right? Electrons, but when it's finally meeting your eye, it's photons. That is just light energy. If you get enough photons together and you jack them up with a lot of energy with a linear accelerator, they can cause damage. And they will cause damage in wherever we direct them. So we're able to focus that high energy light, basically, to kill cancer cells. Now, there's a number of problems with that, right? It doesn't just kill the cancer cells. They're more damaged because they're more rapidly dividing, but it kind of kills everything in the field. So you can have side effects from the radiation, as you know, that radiation dermatitis, immediate post-radiation swelling, and a number of other issues, skin sloughing, that sort of thing, that often will get better. But then later, that radiation is a well-known cause of lymphedema. Next slide. So here's some just typical breast radiation. These are isodose curves. The typical dose of radiation in breast, again, is about 50 gray and 25 treatments of 2 gray. That varies depending on a number of things. You can see up here in the top right slide, a little boost. So that breast may have gotten 50 gray to the whole breast. And then you get another 50 gray just to where the tumor bed is. You see the one on the bottom right, no breast, right? Now we're radiating the chest wall and all the involved lymph nodes. You can see that the lung gets in the field to some degree, but on the bottom doing prone to try to get the heart out of the radiation field, because radiation to the heart is another cause, along with some of the other medications we use, of causing heart disease in breast cancer survivors. Next slide. So what that causes, and again, now I'm doing the thing and give you an extreme example, is radiation fibrosis syndrome. So radiation fibrosis is that slow, insidious tissue damage that occurs as a result of radiation. It damages everything in the field, the skin, the fat, the muscle, the nerve, right? I see this in head and neck cancer patients, Hodgkin survivors. If you've heard me talk before, you've heard me talk about myeloradicular plexular neuromyopathy, another hour or two talk, depending on how wound up I am. That leads to a variety of neuromuscular dysfunctions. In this patient, you have another lady, like the one I showed you before, this time older, who had a simple mastectomy or a simple lumpectomy, axillary sentinel lymph node biopsy, and then got radiation, which turned her breast into a raisin. And this is just for reasons we don't understand. She is much more susceptible to the radiation than other patients. So she's kind of the extreme example. But that's not just the fibrosis. There is a lot of fluid lymphedema because of the damaged lymphatics in that tissue. Next slide. So a lot of things determine how severely you're going to get radiation fibrosis. So the total dose is the biggest thing we look at, but the truth is the size of the fractions is very important. So again, breast cancer, usually 50 gray, the same as 5,000 centigrade in 25 treatments of 2 gray or 200 centigrade each. Head and neck cancer, we do as much as 70 gray, right? And that's very damaging in these patients. Other treatments, right, like the fact that you had a mastectomy or an axillary lymph node dissection, absolutely, as we well know in breast cancer, contributes to disorders like lymphedema. The type of tissue, I'll show you a slide, they have different sensitivities to radiation. Your overall health, that's what I mean by protoplasm. Are you an 85-year-old with brittle diabetes and heart disease, or are you a healthy 25-year-old marathon runner? That's really going to determine how you do with some of these impairments and time. Radiation is the gift that keeps on giving. So it can cause issues years later in our breast cancer survivors, our head and neck cancer survivors, our Hodgkin's lymphoma, anybody who's been treated by radiation. Next slide. And this is just showing you the sensitivity. So lung is very sensitive, it melts. That's why we work so hard in breast cancer to make sure the lung is not significantly involved in the field. Nerve is relatively radioresistant. But what you're looking at here is the total dose to cause a complication in 50% of the patients 5 years. So you see nerve, well, okay, we need 75 gray, right? So head and neck cancer gets, say, 70 gray. 5 years, only a small fraction of them are going to have any issues. Well, what happens if we go out 10 years, 20 years, 30 years, which is what's happening because, hey, we've gotten really good at treating cancer. And it's the same thing in our breast patients, right? A lot of those tissues that are in the breast can get worse over time. Next slide. And this is just showing you sort of the impact of radiation on the incidence of lymphedema. So if you have a sentinel lymph node biopsy and whole breast radiation, it's still like roughly 50%. If they do the whole breast, 30%. If they do the whole breast and then the regional lymph nodes, 40%. So this risk starts going up high. And we're really here looking at arm lymphedema. We're not really talking about breast and chest wall lymphedema in these patients. Next slide. So what are the signs of lymphedema? Well, you guys know swelling, skin changes, pain, discomfort, numbness, tingling, trouble, range of motion, skin inflections. If it's really bad, you can have lymphorrhea. Fortunately, we don't see that much these days. I still see it occasionally in patients with lower extremity lymphedema. It does lymphedema just so you know, it doesn't cause nerve injury. It's actually still pretty low pressure for nerve, but those patients will get a lot of other causes of pain beside it actually damaging the nerve. Next slide. And this is just looking at the progression. I've been playing with the sliders on this slide. I'm still not quite happy with it, but you get kind of the point. You're diagnosed, you go to surgery. Just the surgery itself is going to cause some postoperative swelling. The chemotherapy can cause some additional swelling of the breast, chest wall, and extremity. But then it's really when we start the radiation, it starts getting worse, and it can get worse for a while with just that post evil humor mediated hydroxy radicals that are being caused to be released by the radiation. And that will often get better, maybe not to normal, but then sometime later, it might be a year, it might be 10 years, you can start having symptoms developing both in the chest wall and in the arm. Next slide. All right. And I don't want to spend too much on this. I'm guessing you guys all know this. Stage 0 is subclinical lymphedema. Stage 3 is, basically elephantiasis. We don't see that as much. Stage 1, it's usually kind of reversible. Stage 2 is where we see, most of the patients that get referred in because that's when the oncologist actually starts noticing it. Next slide. Okay, trunk lymphedema. So this is what we're really here to talk about. This is swelling of the breast, the chest wall, the back, scapular area, the lateral trunk, clavicle. And interestingly, because of the nature of some of these flaps, I've got a number of patients with pelvic lymphedema from their deeper tram flap, right, being resected, because as you can imagine, taking that tissue out disrupts the lymphatics there. They often will experience pain in the chest wall, shoulder, and back. The lymphedema itself is not painful, but I think it contributes to other disorders that are. They feel heavy, full, sometimes tingling. Again, I don't think the nerve injury is caused by it. We can debate that in the Q&A if you want. But in my experience as a neuromuscular specialist, I don't usually think that's it. Dry, flaking, discoloration, dimpling of the skin, poda orange we talk about, particularly when you show you the horror show slides of patients with breast lymphedema. The back swelling and even the trunk swelling, any of it can alter how you stand, how you walk. It can cause other neuromusculoskeletal issues. And then the reconstruction really can affect even further how the patient's doing with regard to swelling. Because remember, and again, we're talking about chest conserving, but you'll also see this obviously in patients who have full mastectomy and reconstruction. Next slide. So truncal lymphedema, again, it's just accumulation of lymph fluid in the breast, the chest wall. My best illustrative slide is the first one that I showed you sometimes. You can see it on the back. You can see it on the upper neck. I've seen it kind of everywhere. Sometimes it comes along with Mondor's disease, sort of cords in the axilla. I've seen cords going just about anywhere, including proximally in these patients. Next slide. The etiology, again, all the data is pointing to this being largely because of the increased use, appropriately so, of breast conserving therapy. But I don't think that it's so much the taking out the tumor, right? Or even a sentinel lymph node biopsy, although even isolated sentinel lymph node biopsy has it. But the incidence of extremity lymphedema is certainly lower, as we showed you, than doing a full lymph node dissection. I think it's largely the radiation that is causing the chest wall swelling in the majority of these patients. Next slide. So diagnosing it. So I'm going to show you stuff because it's kind of obligatory. The truth is there's no good way to diagnose it except using your eyeballs, right? Maybe Jenica can tell us more how she does it in clinic. To me, it's really the patient sensation. They tell me, yeah, the breast feels full. I look at it, feels full. I touch it. I, palpate it. I try to see if I can pit the breast. I compare it to the other side and other normal tissues. And even if I don't see a lot of that, I still will send them for treatment for the breast lymphedema, just assuming they have it. Just, cutting over to my other favorite FlexiTouch device, which I use for head and neck cancer. My thing on head and neck cancer, 100% of these patients have lymphedema. Like, you will have trouble convincing me that anybody who's had 70 grade of the neck is not going to have lymphedema in those tissues. And I think the data shows us that, yeah, I'm pretty much right. It's effectively 100% of those patients. I think for the chest wall lymphedema, if you have radiation to the chest wall, we have damaged and caused some dysfunction of the lymph nodes there. So, contrast enhanced digital mammography, I've never ordered that. MRI of the breast may show it, but I don't think it's that useful. This TDC, the tissue dielectric constant, okay, but that hasn't really been honed yet. The truth is, it's the patient symptoms and sort of your clinical assessment. And when in doubt, assume they have it. Next slide. Again, this is just saying what I've told you, and depending on which test we try to use and who's looking at it, the incidence of lymphedema in these patients ranges from 10 to 90%. Very wide, which really just reflects the fact that we don't know enough about it yet. Next slide. Okay, so the ICG, the indocyanide lymphography, green lymphography, this is what a lot of surgeons or several ways will do to map out the lymph nodes. And I really put this in just to show you the next slide, which beautifully illustrates sort of this backflow. So in the front top picture, right, you have a relatively normal patient, has normal lymphatics. You put in the dye and it doesn't end up concentrating in the skin. These both lower patients, you see that dye concentrates. And one of the big points to make here is, yeah, you can massage that out potentially, but it's going to come back. So one of the things I like about the FlexiTouch, as opposed to like a compression bra or that, and hopefully Jenica will talk more about sort of how he gets it out, is that, this manual lymphatic drainage, or better, using a FlexiTouch device, which has the advanced chest wall component, will help make that fluid move. Why is that important? Well, I harken back to my head and neck cancer patients where I'm even more convinced of this. So the radiation itself causes fibrosis, right? Radiation fibrosis syndrome. I can show you pathology slides. I can show you clinically. That we don't have anything to do about. There's no primary treatment to deal with that underlying pathology. But lymph fluid itself is also fibrogenic. It is inflammatory. Your body tries to attack those stagnating sort of proteins that are in there. And it, in and of itself, as you see in these stage 3 lymphedema patients, will cause fibrosis. Can't do anything about the radiation. But if you can get that lymph fluid out and keep it out, then you probably slow the progression of fibrosis. That, important certainly in the breast. In the head and neck, where I see so many patients, this is primary treatment for me, to get them to swallow better, to get them to speak better, to get them moving their neck better, to help a variety of issues that these patients suffer from, because there's a lot of, a more densely packed area of tissues that are going to be affected by that fibrosis in the breast. Not that the breast isn't important. Absolutely, a tight breast, like I showed you in that poor patient had the really bad response to the radiation, can absolutely affect things. Next slide. So again, the incidence, 0 to 90%, just so you guys remember that. Next slide. And this is just kind of interesting that, there's a number of things like bra cup size also would, as you might imagine, affect the incidence of lymphedema in these patients. I thought that was just an interesting study, not to dwell on it, so I can hear Jenica talk. Next slide. So conclusion, this is a common disorder in breast cancer survivors. We don't know the incidence, but it's probably high. I'm on the 90+% side when we really look at it. I think the radiation is the biggest contributor. There's no gold standard for diagnosis, so eyeballs clinical judgment, and frankly, just assume they have it if they're coming in with complaints. I think advanced pneumatic compression is really become an integral part of treatment, and I think it will be. I think we need more studies proving just how important it is. Our goal is not to cure these patients, but help optimize them so they can live their best lives. Next slide. That's me. I think they're giving you these for anything who wants to discuss. That's my very, very accommodating wife who takes trips all over the world with me to chase birds, even though it's not her thing. She does like the penguins, though. There's nothing more fun than a penguin coming up to you and like pecking at your boots. Next slide. And this is just to emphasize how important having a comprehensive cancer rehab team is. Again, I always say it, I'm pretty much useless by myself, which is why I've made a point in my career of surrounding myself with amazing therapists who can make me look good. Next slide. And then now I'm going to turn it over to really the star of the evening, because I've been looking forward to hearing what Jenica is going to say. So Jenica, take it away.
Thank you, Dr. Stubblefield. Hi, everyone. I'm Jenica. I'm an occupational therapist and a CLT. I've been a CLT for approximately 13 years in a rural clinic, like they were saying before. I've seen a number of lymphedema patients, so much so that you would think like, okay, you're in a rural community, you only see a few. No, there was a couple years, that's all I saw. And so as an OT, seeing only that, you learn it very quickly. Next slide. So did you know that, you have to look beyond the arm? When you first become a CLT, the first thing you look at is the arm. Okay, is the arm swollen? No. The fact of the matter is that over 50% of these patients are going to have swelling in the trunk. And a lot of times we don't look at that. We forget to. We don't look at their breast. And yes, it can be awkward. And should it be done? Absolutely. But if we don't take a look at it with our own eyes, if we don't measure it, we don't touch it, then we are overlooking that they have truncal edema. And I know early in my career, I probably missed it. But now that's something, the first thing out of the gate, how does the chest feel? How's your bra fitting? How's your shirt fitting? Because these are things that they forget about, or it's the most irritating thing. Arm's doing great, but the trunk is the worst. Next slide. The importance of early detection. So we'll go further in this later, but early detection is something that I want to get even better and better at, and getting my providers to recognize. But it's detrimental, it's crucial. One of the oncology departments that are within my rural hospital, we're like a sister hospital to a big network, and they know exactly when to refer to us. Right after surgery, referral. Doesn't matter if they're about to get radiation, I want baseline measurements. Early detection allows for prompt treatment, adequate control of the disease. A lot of people, I will tell you, do not know what swelling is. A lot of people have no idea what lymphedema is. So when you start throwing those things at them, and they've just went through the diagnosis of breast cancer and now a surgery, and now they're going to have chemotherapy and or radiation, that's a lot. So having your providers, your nurses, your medical assistants, your primary physicians even, having them know what to look for to get them in your office as a referral. Another thing, preventing the progression. Like if we can prevent it a little bit more, quality of life is so much better, and just making them feel better. And early detection, it promotes good understanding and education of the disease. Next slide. How I assess as a CLT, truncal edema. So we have our volumetric measurements. We all do the arm. If you do it by the 4 centimeter or by the 10 centimeter, depending on what you're looking at. I normally standard 10 centimeter unless I'm doing like a custom garment, or I know I'm going to do a custom garment. But something else to add to that, the trunk. I go axilla to axilla, the bust, the breast line, or where the nipple was, nipple line, and the inframammary fold, right underneath the breast or where the breast was. I target those and I keep an eye on those. And that chart is in all of my progress notes from the lifetime of the patient when they are being seen for lymphedema care. Range of motion. If you're not looking at range of motion, you are missing out. Active and passive end ranges need to be assessed at eval. Scapular positioning. If we get injured, we hurt our shoulder, we hold our arm next to us. If we have surgery, what do? We hold our arm next to us. We have to know where the shoulder blade is in position. Why is it contributing to my swelling? Why is that a big factor? Well, if our shoulder blade is not moving correctly, our arm's not moving correctly, now we have high prevalence of swelling. Photos. You got to take photos. Now, I will say, make sure the patient is understanding that these photos are going into the EMR, that this is for them to document, and that so if there's a change, a picture is there for us to notice it. Their doctor can see it now, we can see it now. And on top of that, like sometimes you miss something when you're assessing, but if you take a picture and then later on you're doing your documentation, I tell you, there's so many times that I have missed something. Look at the fold, look at the flank side of the shoulder blade, look at the front and back, symmetry. The right doesn't look the same as the left. Skin assessment. Yes, you have to touch them. You have to touch the skin. You need to touch around the breast, around the axilla. You need to know what they are feeling. And obviously you need a patient report and understand and listen to patient report. Scars. Where are their scars? Not just their scars from their breast surgery, but also other scars. Because when we are doing manual lymph drainage, I am not wanting to go to part of the lymphatic system that has also been compromised from, say, another surgery. Posture, just like we talked about earlier, if you get injured, your posture changes. We have to correct that posture. We cannot just zero in just on the swelling. We also have to look at the things around it that are contributing to it. Neurotension. So I work in an orthopedic clinic, so I see a lot of joint replacements and stuff like that in addition to swelling, and I cross over a lot. And neurotension gets overlooked. They complain of pain, but it's not like you can palpate and it's pain. They complain of something going down the arm. Median nerve, I don't know why, just the placement of it, especially with mastectomies, usually the median nerve is caught. So I always check the main nerves that go down the arm, the radial, median, and ulnar nerve. Axillary cording. This can be as tiny as a hair. It can be as big as a rope. You have to get your hand in the axilla and really feel around. And past medical history. Be thorough on this. In my chart, you will see at the very top, if it's a lymphedema patient or anyone that's had lymphedema, you are going through their past medical history. And if you see them in a year, you're going back through that because things change. And like we talked about, patient report, heaviness, tightness, pain, hypersensitivity, bra size, shirt size. Next slide. Patient education. So part of this is patient education because once you have lymphedema for life. So if they don't understand it, they're not going to try to treat it on their own or help treat it on their own or have good carryover at home. So self-manual lymph drainage. Yes, it's okay. It's fine. It's good to give out, hand out a video, a demonstration. You got to figure out what they need to have this carryover at home. And this is all before you get the pump, right? Muscle pump. So we think, okay, their arm's not moving that well. What do I do about that? Well, you got to have active assisted, passive range. I stretch most of my breast cancer patients because, there's fibrosis, there is shortening of a lot of the muscles, and you have to work on posture. You have to stretch the joint. Remedial exercises. This is your decongestive exercises. Every patient that comes through my door that is a lymphedema patient gets decongestive exercises, and they are taught how to do them properly. So that is from proximal to distal, distal back to proximal. I have these, and these include diaphragmatic breathing, which is around the trunk. And diaphragmatic breathing it helps with the lymphatic system. It's very important to pair up with these remedial exercises. Aerobic conditioning. So most of my patients think, okay, well, walking, what does that have to do with my lymphatics? And why is that going to help me? Well, aerobic conditioning is that, uses large muscle groups. And through rhythmic and repetitive use, it increases your cardiovascular exertion, which increases your heart rate and your oxygen. The smooth muscle contraction rate in the lymph system increases. The negative distal pressure encourages lymph reabsorption. So that can be walking, running, cycling, something even better, get them in the pool. You have compression now compression on the whole entire body in addition to their exercise. And then resistive exercise. I work a lot on scap strengthening. After their volume has went down, they've gotten their compression garment. We work on recruiting the proper rotator cuff muscles, the proper scapular muscles. Proper scar massage. A lot of them they don't want to touch their scar. They don't want to look at their scar, let alone do a scar massage. So I teach them how to do that. Now, being a CLT, I'm not going to rub on it until it goes completely numb or anything, but I want to make sure that they don't have any adhesion. I don't see this as much. And Dr. Stubblefield touched on this a lot in the fact that 13 years ago, I saw more radical surgeries, you would say, or those older patients that 30 years ago had those radical surgeries. I don't see those much anymore because we're becoming more conservative. We're more precise. Our imaging and diagnostics are so much better. However, scarring still can cause problems. So make sure that you're doing a proper scar massage and teaching them how to do that. Wearing the proper reducing compression, followed by transitioning to the proper daytime garment. Already stated this, but aquatherapy, if you have access to a pool or your patient has access to a pool, by all means, they need to be getting in a pool. The pool gives you the most millimeters of mercury pressure against you, the further deeper down you get into it, than anything. And so if you pair that up with their exercises, their decongestive exercises, walking, their aerobic exercises, resistive exercises, you are now stimulating all parts of the lymphatic system to help with decongestion. The advanced pneumatic pumps, they keep getting better and better. And the fit of them and how to get them on and off keep getting better and better. Risk and reduction practices. These have to be reviewed you have to go over them over and over with patients, risk of infection, risk of injury, all these things, because they forget there's so much information packed into that short period of time after their diagnosis that we then give a whole bunch more information. I highly suggest giving handouts, packets, videos. Every time they come in, they get the same stuff. Next slide. Manual lymph drainage. So we were taught in school that, manual lymph drainage, we have to do either supine, laying flat, looking up to the ceiling, or prone, laying on our belly. Oh, some of these patients can't do that. I probably maybe 20% of my patients can lay on their belly because of pain. Maybe they have just, a bigger stomach, large pannus, whatever it may be. But at the end of the day, try sideline. Sideline with having the involved side up, you are now against gravity. Move the arm around, get to the trunk. You can drain the area so much better with your manual lymph drainage that way without having to put them on their belly and prone. Again, past medical history dictates your manual lymph drainage. And if you don't know where they have scarring, then you might be doing something detrimental to their lymphatics in other areas. So I make sure that I have that marked in my chart at all times. I'm not going to the right hip because they just had a right hip replacement, but I'm addressing the right arm. So in the options, and we learn these in our school of whatever school you went to became a CLT, but remember that we do not want to send fluid to a compromised area, no matter what we're addressing, breast cancer or not. So make sure you know your past medical history of your patient, and it's very thorough. Next slide. Compression. Compression is hard for truncal edema, and we all know that. And so one of the things that I've tried to help with truncal edema and finding options for especially my female patients is comfort. The biggest thing is comfort. They're usually hypersensitive. When they're so swollen, it's uncomfortable. They don't want to put anything against it, but they need the support. Finding a bra that actually fits. And a lot of them don't want underwire anymore. I don't blame them. I get it. But finding a bra that you can add foam or compress, so it can almost act like a reducing compression, and then it becomes a permanent compression where you can size it down. Compression tanks are fine. There's a lot out there. Medi has lots of great products. My go-to options, TheraWear. I don't know if anybody's heard of that. I pair up with them actually, and the bra in the black right there, that middle, it allows it to expand, and then you can bring it in as they reduce. That exact bra, which is the Hugger Prima, it goes all the way up to the axilla. It provides really high support. It's almost like your post-surgical bra. It's their highest grade of compression. You can add foam, compress, whatever you need to the breast, to the axilla, whatever the problem areas are. The other really good go-to is the Circade Reduction Kit vest. Reduction kits I have used for years, right when they came out, and they've tweaked them over the years, but the vest is now a newer thing. What's nice about it is if you haven't used a reduction kit, it can be a reducing garment at the beginning of therapy, and then it can become a permanent garment as needed. The other cool thing about reduction kits is if you're in a hospital setting and you need to have some type of compression, but you don't want to wrap them all the time, reduction kit cost, in addition to, or compared to short stretch bandage costs, is actually less, and they take less time. So not only addressing the trunk, but the arm has a good piece with the hand. Those are all great reducing agents that then can become a permanent garment, or it can get them transitioned to a good daytime garment. Next slide. Emerging treatments and innovations in lymphedema care. So I try to look up stuff all the time. I try to keep up with what's going on. And a lot of times my patients are very educated by their surgeons or their oncologists. But advances in lymphedema, there's been a focus on the genotype and the phenotype relationships in primary lymphedema. Primary lymphedema, I think I'm recognizing more and more of later in my career, just because I'm more well-versed in it and what to look for. Other things like imaging. Imaging with the magnetic resonance lymphography that can evaluate the lymphatic system. It can differentiate between the lymphatic versus venous causes. Surgeries, a place really close to us, a hospital really close to us, is doing the axillary reverse mapping, where it maps the arm before you do your lumpectomy or mastectomy or axillary node dissection. Because it's trying to preserve, again, being as conservative as possible, because we all know the lymphatic system is very delicate. And one of the things that is a hot topic in my department right now is chronic inflammation and the correlation with that with lymphedema. There's a lot of studies that I looked at, and it's suggesting that there's anti-inflammatory interventions may be of the future and are already here. But lymphedema is largely stated to be associated with inflammation, that adipose tissue deposits. Therefore, reducing the progression of these with anti-inflammatory would reduce lymphedema. Next slide. Emerging treatments and further with innovations with lymphedema care, the lymphovenous bypass surgery. I've been seeing more and more of this. I do have a couple patients that have had these before, where they're connecting the lymphatics to the venous system. Remember, the lymphatics are right there by the venous system. So they're going around the affected area and draining into the veins directly. Vascularized lymph node transplants. They're taking lymph nodes from a healthy part of your body and putting it next to the affected part of the body. Compression garments. If you don't know, and I know there's a lot of CLTs out there that do not know this, but the Medicare population is just getting bigger in the United States. So you have to be pretty well versed in Medicare. And I don't like talking about insurance, but when it pertains to my lymphedema population, this is key. They are now paying for compression, which also includes compression bras. So Medicare now of January 1st of 2024, the Part B will pay for anything with compression when you have a diagnosis of lymphedema. This can also include the donning aids, the fillers, the linings, the paddings, the zippers. They will also replace, if you have a significant reduction, the garment. You get 3 daytime garments per part of the arm or leg or trunk every 6 months. So if it's your arm and you need one for arm and hand, it's 3 for the hand, 3 for the arm, 3 for the trunk every 6 months. They also do 2 nighttime garments every 2 years. So finances do factor into our lymphedema care. It just really does. And up until now, my Medicare population really had to pay for out of pocket. And my population has that compounding disease population where, yes, they have lymphedema, but they have the cardiovascular problems. They've had the diabetes. They just have so many things going on. And so now if this can be covered, now you as a therapist have to pursue this in order to get this to them, but they can get it covered. And I have had it happen for this calendar year. And then advanced pneumatic pumps just are more concise. They're getting the sizing of them fits better, and patients are just having better carryover because they're getting the education early. And so they know how to manage their care now. Next slide. The FlexiTouch. So the FlexiTouch, before even doing this talk, my go-to pump is the FlexiTouch. Has been, always will be, because it just provides good support. It's clinically proven. It's consistent, convenient, comprehensive, and it's comfortable. I know how old a FlexiTouch is with my patients by the color. That's how long I've been around. That's so weird to say, but I will say, what color do you have? Oh, it's the brown one. I'm like, oh, okay, we have an older one. Okay. So, but they just have been that go-to company. When I was trained to be a CLT, that was the go-to, and it still is. Next slide. The FlexiTouch Plus Comfort E. So this is the newest garment, with the vest and the arm, the upper, the shoulder piece dysfunction. And it addresses, it does the MLD, but it addresses it just like we do as CLTs. It has multiple pressure settings. It's easy to put on and off. It's the zipper pull. So I just got this for a patient that has poor range of motion on the other side because of an orthopedic injury. And just having that ability to unzip is so much easier than the Velcro for them. It also has the back handle loop in the back for the garment, and it has the supplemental programs. So the supplemental programs, what that means is you can customize it. And, if it needs less pressure or more pressure because of fibrosis, less pressure because of hypersensitivity, we can help as CLTs dictate that and provide that support for good carryover at home. Because if it doesn't feel good, they're not going to use it. And we always want to make sure they're using it. One thing to remember, as in eval, to get your pump, when you have your eval, this conversation should be happening right then and there. It shouldn't be later on towards the end of treatment, because I will tell you, getting a pump takes a while because they need all the documentation. We have to run it through insurance, and you want to make sure you have everything you need. If you wait to the very end, you probably skip something. Even us well-versed therapists, we might skip something, or insurance is requiring this specific measurement. So make sure this conversation piece happens at the beginning. Next slide, please. Customizable treatments. I've used basically all these different types with different parts of the garment, but the unilateral, just one arm. So you have the arm, the vest, and the trunk piece. Then the chest only, that is going to be it going inwardly from with no arms attached. And then simultaneously, this is your bilateral mastectomy patient. And what is important about that is they can do that at the same time. Because sometimes they're like, oh my gosh, I have to do one arm and then the next. No, you could do them all at one time. Next slide, please. Like I mentioned before, it can be customized. It fits really well in the axilla, and that is usually my women's complaint, is getting that support underneath the arm. And so if we have a garment that does that and does it well, we know that the carryover at home is well, and we know that they're using something that is simulating what we do, which is the manual lymph drainage. Again, it's easy to don and doff, and it's just a little bit less. The new one now is just thinner and less bulky. Next slide. Here's the treatment options for the breast. We have the chest only. We have the unilateral, which we saw earlier, the chest only inward and the chest only outward. I should correct myself on that. And the simultaneous bilateral also. Next slide, please. Flexi touch in my practice. Next slide, please. So looking at truncal and breast edema, like we have said, you have to look beyond just the arm. We have to take the pictures. We have to see what is the breast doing, the side of the arm, the chest, the back. Look at the shoulders. This picture right here actually is ideally what I always look at the shoulders. I'm looking at where's the curvature of the fat tissue, essentially. Where's the swelling? Where's the indentations? Where is the bra sitting at? Why are they uncomfortable? Truncal edema, as mentioned before, 50% of breast cancer patients are going to have truncal edema. And one thing I want to hone in on is that the fact that we are the CLTs, right? So even if you have your therapist right next to you is like, oh, I can take that patient, even though they have a history of breast cancer and it'll be fine. I'm just going to touch up. No, you are the CLT. You are the ones that have the eyes to look at these patients. And in our clinic that I've worked at for 13 years, they don't get those patients. The CLT needs to look at them. And I know over the course of, years ago that it was like, oh, anybody can see them. No, us specialists need to be the eyes of looking at these patients, make sure they are getting the resources they're supposed to get. Next slide, please. Okay, does the Flexi Touch provide the right support? So evidence has proven that the Flexi Touch does actually do what it says it does. So in the study, there were 6 cancer patients. 3 are just the normal control patients. They injected a icy green dye in them, and then they seen where it went. And they were looking at the lymphatic propulsion rate, the velocity, and the lymph vessel recruitment. Next slide, please. They saw that when they did this and they used the Flexi Touch, that it not only helped the involved side, but it also stimulated the lymphatic system on the uninvolved side. So what does that tell you? It tells you it's doing the manual lymph drainage just like we do as CLTs. So it's simulating exactly what we are doing as therapists. When I went to my CLT course, we did MLD on us, and they're like, oh my gosh, why do I have to go to the bathroom all of a sudden? It's because you're stimulating the lymphatic system. So even in this control group, they were seeing that there was movement within the lymphatic system. Next slide, please. Does the advanced pneumatic pump use enhance the clinical outcomes of patients in comparison to self-MLD? Next slide. Well, I will tell you that it does, but the study does back that up. So there was a comparison in, there was 14 days that they had the Flexi Touch use versus self-MLD. Now, Self-MOD is fine, but it just doesn't do as good as like a FlexiTouch could in this case. After they did 1 hour of therapy for 14 days, the result was that the FlexiTouch reduced by 208 milliliters. The self-MLD increased them by 52 milliliters. In addition, the weight decreased significantly with the FlexiTouch use, so 2.3 kilograms. And with self-MLD, there was a 0.5 kilogram increase. So there, the FlexiTouch, because there's that truncal component, it just helps with stimulating the lymphatic system overall. Next slide, please. Generating referrals. Okay, so this is hard when you are the only CLT. No one knows you exist. Nobody knows how to get to you or that you even work at the clinic. You have to educate. You have to put yourself out there. As we know, there's not enough CLTs in the nation. Lymphedema seems to be growing, or maybe just the diagnosis being known is becoming more known, with the increase of obesity. Like Dr. Stubblefield said, we just see a lot of swelling now. And so you have to educate all tiers here, including your medical assistants, your nurses aides, your physicians, your nurse practitioners, the people that are seeing these patients in their clinic. Creating rapport with surgeons, oncologists, primary physicians, wound care staff. I have done classes with all these over the years, and you have to continue to do them. We know turnover, people don't see you, so they're like, oh, do we have a CLT? What is a CLT? Why do I need to send it to a specialist? It's important. And if they don't know you're there, you don't get the referrals. Patient and families have to know the first signs and symptoms of swelling. If they don't know, they're not going to say anything to their doctor in their oncology appointment or their post-surgery appointment because they don't know what to look for. They think it's just surgery. They think, okay, I'm going to have a little bit of swelling. And in the past, a lot of times it was said, oh, you'll have some swelling and it'll be okay. That is when I want to see them, is when they just have a little bit or just out of surgery. Educating other people that you work with, other therapists. They know what you do, but they don't really know what you do. So if they have a patient they're seeing, and maybe they're seeing them for, shoulder pain, but this is a previous breast cancer patient, and, we're like, whoa, we need to get a referral. They need to know how to do that and the steps to do that and the signs and symptoms to look for. So you have to educate the staff that is literally working right next to you. Educate other departments. You need to know where you can get a doctor's order, how to get a doctor's order. Documents need to be clear, concise, easily accessible. I have done radio interviews. I've done newspaper articles. I've done social media ads. I've done it all. And because people just don't understand the importance of swelling and what it can do if it's not treated. And encourage referrals immediately after surgery. Get those baseline measurements. That does not only include volume measurements, but your range of motion, because without them, you don't know where they're really at or where they should have been. So encourage the early referrals and make sure the patient understands the importance of it. Next slide, please. The conclusion to all this, managing swelling. It just lymphedema in the arm and trunk has so many components. So starting the process the earliest in the stages shows an improved correlation with lymphedema management. Compression pump conversations need to start at eval. I repeat, compression pump conversations need to start at eval. Every document that you make, every eval should be set up that this person's going to get a pump, because at the end of the day, you don't know, depending on insurance and if the patient wants to, but you already have it set. And so it's ready to go once they're getting closer to discharge. It limits the delay in retrieving a pump to a patient, decreases the risk of volume refill after discharge from therapy, and improves carryover at home. Lymphedema education is overwhelming to most. Provide handouts, demonstrations, videos, online resources are all important. Review these periodically. And lastly, build rapport with your staff. Don't be afraid of the doctors. Don't be afraid of the oncologists. They need you as much as you need them. And most individuals just don't understand it. So if we educate the staff and we have everybody on board, then we'll get the referrals properly. Thank you so much, you guys.
Excellent. Thank you so much, Jenica and Dr. Stubblefield. The questions are pouring in, so we'll go ahead and get started with some Q&A. I've had several similar questions, so maybe we'll start with what we're seeing the most frequently. And I've just got to say, Jenica, I loved your statement about taking photos and really pointing out to the patient that it's for the patient and comparing their own symptom improvement. That really stuck with me. And so thank you for sharing just so many good tidbits. My phone is blowing up with everyone that's been watching. So thank you so much. So Jenica, the first one is for you. So what are some ways to measure truncal edema?
So I do it at the axillary, so axillary to axillary, across the breast, right at the nipple line or where the nipple line was, and then right at the inframammary fold, so right below where the breast would like end, essentially. And I have that do
Circumferential
that with,
measurements.
yes, all the way across the trunk, yes. And I even
So
go down to the umbilicus, like right before the hip, if I'm dealing with someone, depending on their surgery, but just to have that, if they're complaining of like their abdomen is feels swollen or puffy, I'll do it there.
excellent. Circumferential measurements. I love, like I said, I love the photos. Any other ways that you're documenting the truncal lymphedema if there isn't swelling, if it's more fibrotic, like Dr. Stubblefield was mentioning?
Patient report, comfort of bra. That is the biggest thing. People want something comfortable, and once their volume is reduced, they usually have a good bra. Then they feel so much more comfortable that way.
Excellent, excellent. Thank you. Jenica, the second one's also for you. Can you give an example of remedial exercises, how this is different from self-MLD or resistance exercises?
So the remedial exercises are targeting the lymphatic system. So it's going proximal to distal. So closest to the trunk, down to the arms or the fingers, all the way back up to the trunk. There's a good handout. I believe it's on I'd have to look up the website that I use, and I have tweaked it over the years.
We might be able to share that as a follow-up as well.
Yeah.
That's a good idea. Excellent. The next question, Dr. Stubblefield, this one's for you. So one of our local cancer treatment centers has moved to 5-day radiation treatment. Can you give some insight into this, as this is new to me?
Yeah, so there's a number of ways to give radiation. So when you look at some of the data, when I'm doing my radiation talk, I'll show a slide that shows that when they go up on the total dose of radiation to like 60 gray and the size of the fractions to like 300 centigrade each, your risk of brachial plexopathy goes up to like 70% at 5 years. I mean, just abysmal. So, and that was done in countries like India, where the linear accelerators were very rare and they were playing with different ways to try to improve it. So what you're seeing is somebody has a protocol at your hospital that is probably what we call a hyperfractionated protocol to try to minimize it. And I'm sure there's data behind it. I can't quote it off the top of my head, saying that that approach is as effective, at least for tumor control. The problem is they don't always look at long-term complications, but at least is effective for the tumor control. So just another kind of example to give you. So for like spine radiation, you can radiate a spine tumor. Standard radiation is 30 gray, so in 10 fractions. But we can actually do 24 gray in 1 fraction. It's much more biologically effective, but it's also a lot more expensive to do because of the computer mapping that needs to do it. So you're just looking at a different protocol in your hospital. And if you ask them, I'm sure they'll brag all about it, tell you how great it is.
Thank you. Thank you so much, Dr. Stubblefield, for sharing. There's another question for Jenica. If there has been a history of DVT, treatment has been completed for the DVT, what is your approach toward trunk edema related to MLD?
So first of all, I'm going to refer, even if the patient is reporting that it's controlled, I'm calling the doctor on that. You know, did they put in an umbrella filter? Is it really controlled? Can I do manual lymph drainage over it? A lot of times I'm being pretty conservative about this. If it's something dealing with the arm and the trunk, you know, compression and more of the deep sequence might be okay. But again, this is all going to be directed by the doctor who is understanding the lymphedema, and which I have a staff member that he sends a lot of DVTs, people that have had DVTs, and he understands it. And he, you know, it lets me know when, no, this is not controlled, no MLD, it's contraindicated. In addition to that, as great as our patients are, we are the experts in making that decision. And so always erring on the side of caution, because MLD is powerful in the fact that we have to be smart on how we do it. And that's why past medical history is key in this.
And
Excellent.
if I
Thank you
can
so
just
much.
chime in on this one a little bit, because this is a conversation. Back when I was a medical resident, somebody had a DVT on, say, the inpatient rehab unit. We'd rest them for 5 days before we could touch them, which was physiologically nonsense. Then we came out with the low molecular weight heparins, and all of a sudden, a young woman would come in on birth control with the DVT, would get her a shot of Alovinex and send her out the door, and they didn't drop dead, right? Which kind of begged the question of why we were resting them for 5 days in the inpatient unit, which now we could never get away with. So it kind of moved into our therapeutics. So generally, from the physician's point of view, as soon as they're therapeutic on their anticoagulation, I think it's reasonable with manual lymphatic drainage. And I think to Jenica's point, there may be some patients you can't get them therapeutic for some reason, or they don't have they have another compelling reason. But we don't know, just so you guys aren't terrified. The truth is, our MLD may actually help, right? Keep them from progressing the blood clot. We honestly don't know, but our clinical experience with the low molecular weight heparins in particular, and some of these other new agents, is that, yeah, as soon as we make anticoagulate them, it's probably fine. Anyway, long-winded, but great answer, Jenica. I thought it's fantastic.
That was a good addition. Thank you for pointing that out. I will
Thank you.
say our chat is blowing up. We have almost 30 questions,
Yeah,
so we're going to
like
get through
what
as
happened?
many
Yeah,
as many as we
I'm here all
can. You
night.
guys are the conversation is going. We'll be here till midnight. We'll definitely we asked our speakers to stay on for a little while longer, so we'll continue to answer some questions. And if your question goes unanswered, we will follow up. So just to put that out there. Okay, so a question for Jenica. Do you educate all lymphedema patients on pneumatic compression or just the ones that struggle with MLD? Also, what does that education consist of?
I educate all of them. I have a packet that's already ready for everybody. I want them to know the options, even if they're like, nope, it's not for me. I've given them that information for carryover and for maybe later on, because at the end of the day, a lymphedema patient, you're not going to see just one time. You're going to see them in a year. You're going to see them in 2 years when things are not managed right. Maybe they had a shoulder replacement now on the other side, and now their swelling is kind of getting out of control. And so then they're like, hey, now it's time that I want to do a pump or more advanced and be more advanced with this. So I want to make sure I'm educating them. It just at least going over topics. And I always tell people that this is a lot. Absorb it, read through it, come back with questions. You're not going to know all of it in one treatment at the eval. But it's important that they know their options are out there.
Excellent. Thank you. And then what are the measurements of the trunk on the eval? I think you kind of mentioned that maybe one more time of where you measure the trunk.
Yeah, so axillary to axillary, so around the trunk at the highest point to the axilla, across the breast line, and right underneath where the breast would end. And then umbilicus if needed.
If needed. Here's a specific case, but I've heard this a lot as far as positioning. So one of my patients has the FlexiTouch and only has breast and truncal swelling. She has issues being able to tolerate laying flat supine due to lung disease. She's also a bit round. So do you have any suggestions for increasing comfort or positioning for chest and trunk garments?
I mean, they can sit up. Here's the thing. With patients that are more complex, in regards to lung and heart, I take vitals before they ever put their pump on, and I make sure they do that at home because, if comfort's one thing, but are they having shortness of breath? And putting more upright with the garment on, I know it's not ideal, but if that's a way for them to use it, then I would say that would be, my way around it. The other way, sideline, if they can be in sideline, depending on the position or switching it up. Even modifying, and this would be with the rep, like how many minutes, how much can they do? Can I do a full trunk sequence?
Definitely. I will say I've noticed that with our breast and chest only, sitting upright is a bit more reasonable because, we're not elevating the breast and the chest anyways.
No.
We're kind of so it has been a little bit more reasonable, and it also allows the treatment in the chest just to lay flat against the skin, where sometimes when they lay down, it rides up.
It rises up, yeah.
And so then they get a little bit, uncomfortable with the neck piece. So I have had better experience with patients sitting upright, and that can certainly help with compliance and positioning to make the patient comfortable. So thank you for that one.
The other thing too, I would add to that is asking what pump they are using. So a lot of times people, you can't replace a pump, like it's Medicare. Medicare I hone in on because I deal a lot with Medicare. A replacement pump is like every 5 years that they'll start replacing that. So if they have an old pump that's ill-fitting, they've increased in size, they've decreased in size. This recently just happened. And they're like, it's not doing what it's supposed to, but it's working. It's because it's not fitting properly. It needs to be refit. So having those discussions with your rep, your tactile medical rep, and making sure the fit is ideal for them also is another thing.
That is an excellent point. It's usually the fit, and we need to do a little training or send them some resources or make sure that they're actually getting a better fit. Great point. Here's another one. How soon after surgery can a patient start truncal compression pump?
So I normally see them. It just depends on the doctor, and maybe Dr. Stubblefield has a better like protocol of what he usually does. But I see it varies. I see them right after surgery, and I see them. It could be months after, and so it just varies when they get to me. But Dr. Stubblefield, do you have a protocol?
Yeah, it definitely depends on the surgeon. They're in charge of their wound and they're very protective of their wound.
Yes.
I don't think the pump is enough pressure that you're in any real danger of opening up a wound, with the exception of there was necrosis, it wasn't a good flap, we're worried about it failing, it's a dysvascular patient with diabetes. Right. So the surgeon often will, like, when the hair on the back of their neck goes up, that's when they'll kind of usually tell you, maybe we'll just wait on a little bit. And that means they know something that may not even have made it in the operative report. Generally, at 6 weeks, everybody's healed, but there's no reason not to start it, 3 days after surgery or even the day of surgery if it's a really well closed wound. But that's really necessary, right? So you don't you always have some time. It's not like you're going to save the patient a lifetime of trouble by starting it immediately. You can wait a little bit. It's generally okay.
Excellent. Thank you both. Another question. We're seeing more research pointing to the benefits of prophylactic compression of the arm to prevent arm lymphedema. Do either of you recommend prophylactic compression bras or some type of compression for the trunk?
So I recommend compression bras if you can get the right fit. Like I said, they're hard. Compression bras are one of the hardest things to size for people and get the right comfort, because us women, we're particular about our bras and how they fit. The one that I've been going through the most lately, though, is that Prairie Wear, just because it's more streamlined, it's thinner. But then if they're having a large volume, especially in the breast or in the axilla, the reduction kit is ideal. And it's pretty affordable too. They can don and doff of it on their own, and we can size it to them. So that's kind of the 2 point, the biggest things I like to hone in on, because if not, it's hard to get a good fitting compression to them. The other thing is, if wound is healed, I don't want people to forget about aqua therapy. Water, it provides a lot of compression. But again, that's usually further down the line, because wounds are healed, everything's good, they're cleared. But that's another option if they cannot tolerate any compression bra.
Excellent. Our audience is hanging in. We still have 200 people on, so I'm going to go through a couple more. I'm very impressed. I know. I'm like, you guys might get a little tired, but we'll go through a couple more. Okay, so just started at a full-time inpatient rehab hospital. And any recommendations on how to get the education started in service with nursing staff, luncheon with MDs? Any suggestions would be wonderful.
Lunch with the medical staff is ideal. And, a lot of doctors don't understand it. It's not that they don't know about it. They know what, swelling is, but they don't understand the importance of it and why do I need to refer to you to control it? You have to also educate them on how this is impacting quality of life and what can it turn into? There's stages of swelling. We want to keep them at the lower stages. We don't want to let them go on to the later stages. I want to see people at stage 0 or 1. I don't want to see people at 2 or 3. And a lot of my physicians now refer to me. They come in here with the naked eye. You're like, do they have swelling? You go to measure. You're like, man, they did good. They sent them to me early. That's what I want. But it takes a lot of education at different levels. You also have to educate your general population. So in a rural community, you send out something, you don't know who's reading it or seeing it. So we do radio, we do social media. We talk to the doctors. We also have cards that have that I'm a CLT that are in the doctor's office, and they can hand them and be like, this is her, this is the person, this is the contact. It has to be accessible, and you have to make it kind of easy for them in order to get to you, if that makes sense. But educating and doing it every couple year or so, because when your nurses turn over or nurses advance to other floors or whatever, the new nurses have no idea what you're doing or why you're there. So it's not just a one and done. It's a constant thing.
Excellent. Thank you so much, Jenica. Next question. How do you know when the swelling in the breast or trunk is just swelling from the surgery? And do you still treat the swelling if you think it is post-surgical swelling? If so, how do you know how to provide recommendations? This actually makes me think about Dr. Stubblefield, your slide on progression of lymphedema and fibrosis. Can you speak to that slide and this question?
Yeah, I think if they have postoperative swelling, they're probably going to have some lymphedema. That means there was a lot of damage. Right. So, and it's very rare that somebody doesn't have it. Again, I'm kind of the mind that anybody who's had radiation has lymphedema in the breast just from the dysfunction from that. It may be subclinical and never bother them their entire lives, but I think a lot of them it will. So I don't really differentiate that much. I used to say, oh, if it goes away, but then it doesn't really ever go away, or then it comes back like in my slide some couple of years later. So I kind of just assume they all have it. It's safe for them.
Yeah, and I do the same. And I always tell people, you might not have it now, like they don't feel like they have it, but then later on they get a sunburn, they have an injury or whatever, and now they have it full-fledged. And so if they would have known the symptoms of it beforehand, they might have, caught it earlier. So usually after that, they usually have it.
I told myself we'd go to 8:15, so I'm gonna do two more. So one of them, this is a good one. Do you have a patient sign a consent form for the photos you take in clinic?
Yes.
Sign a consent form.
And video, if we do video, there's a lot of people that don't want to do a handout. They're like, I'm going to lose that. I'm not going to do my decongestive exercises. And so I have them sign a release and I take a video of them doing it and walk them through it. But again, that's facility to facility. You got to make sure that you're okay. That facility is okay with it. But yes, it's covered within our documentation, like what they sign off on. So it's already covered with that. But yes.
You then store those in the medical record. You upload them to the chart.
Yes. Yeah. Yep.
Excellent. And then final question, what do you recommend for initial garment status post lymph node dissection, radiation, breast surgery, but no observable or measurable swelling? Or do you?
I always want someone to have access to a garment because the minute they go flying, the minute they have an injury, prevention is key. And they'll be like, oh, it's fine. But now I get on an airplane and, the air is less and now I want to swell. So, finding them a compression bra that if it's more about their comfort and appearance, then we go that route. But I don't have like my go-to, obviously I keep saying Prairie Wear, but there's all different ones out there. Some people come in with options and be like, will this work? My go-to sleeve is, if you can't do custom or they don't need custom, is a Medi Harmony sleeve because it's the most customizable sleeve that I can find and it's affordable for the patient.
Excellent. Thank you so much. As I said at the beginning, this was our first of a series of 4 Breast Cancer Awareness Month webinars. So please join us again. The next one will be October 16th, and it will be a CEU course. And then we will have, 2 more to wrap up the month. So excellent content, Jenica and Dr. Stubblefield. We will share the slides afterwards, and we'll certainly answer the questions that were asked in the chat that we didn't get to. There were almost 40. So certainly just really good conversation throughout.
You just hit 40.
We just hit 40.
Unless the last one was a thank you.
That's when you know. That's when you know the content was very, very good. 41 now. So we will definitely get to the questions, individually and share the slides. But thank you. Such incredible content. We appreciate you both. Have a wonderful evening.
Bye, everyone. Thank you for inviting us. Bye now.
Yeah.